I think generally speaking, as a profession, most clinicians now are, fearful of the consequences of getting it wrong, if I can use that phrase.
You're listening to the Dental Protection Podcast, and this is the In Dentistry series, where we explore some of the challenges in dentistry today and also discuss some possible solutions. My name is Dr. Noel Kavanagh, Senior Dental Educator in Dental Protection's Risk Prevention Team. And today I'm joined once more by Dr. Raj Ratan, Dental Director of Dental Protection. So Raj, today I thought we'd discuss the whole area of clinical decision-making in dentistry. This is obviously an integral component of what dental healthcare professionals do all day, every day. When a patient, consults with us, maybe with a problem, we gather the appropriate information via, history taking, clinical examination, special tests, all the stuff that we, all learned as undergraduates in dental school. And then we integrate and interpret that information to make a working, be it a differential or even a definitive diagnosis. I think as clinicians, we would all like to think that our clinical decision-making is objective, that it's rational, logical, reasoned, and, unbiased. But I suppose the question that I'd like to address in this podcast, is that always the case? Because, behavioral or neuroethics tells us that there are many factors that can influence our decision-making. Things like cognitive biases, heuristics, and our own, I think it was Banerjee and Greenwald, they had a book called, Blind Spots. So I think our listeners will find it, very interesting and useful to maybe hear your thoughts on this subject.
Thank you, Noel. Yes, indeed. So I think most of the time, and I think it's important to draw a distinction when we talk about clinical decision-making, because most of the time, a group of clinicians would be in agreement over a particular diagnosis. We gather in information, we process the information, we draw a conclusion. So I think most of the time clinicians would look at something and say, actually, this is what I think the problem is, and others would agree. The challenge arises when there is more than one option for treatment. Yeah. So there's the decision making around the process, the psychological process or processes we go through to make the diagnosis. So we pause there. And then the second part is, having made the diagnosis, the patient now has a choice of options. So typically, patient comes to you, they've been up all night, pain upper right quadrant, you take a radiograph, you see caries on the upper right 6, and you draw, you make a diagnosis of irreversible pulpitis. So that's part one. Part two is a conversation with the patient now around the options. Do we extract? Do we try and do a root canal treatment? And if we do a root canal treatment, what other treatment might be required? And I think the challenge arises with the second phase, i.e. in terms of how we make decisions or how we guide the patient, or how we give the patient choice and how we frame those decisions.
Yes. And even just rewinding back there, to our decision-making in relation to even the diagnosis, do you think sometimes, as clinicians, we can jump to conclusions, perhaps, too quickly? And I'm thinking really around, patterns and associations of symptoms, maybe from previous patients that were nearly jumping the gun, so to speak, kind of with mental kind of shortcuts. Do you think that's a potential problem?
Yes, you're interesting. You use the word mental shortcuts, the phrase mental shortcut. That's exactly what happens now, because, if you talk to most dentists will say to you that they have days, and I've said it to my nurse a few times over the years, and it's 3:00 in the afternoon, you've seen 4 patients during the morning, say for emergency appointments or whatever, and that's probably quite a lot, but let's say you've seen 4 patients, and you say to your nurse, it's a day where we seem to be doing a lot of endos today.
Yeah.
And what that really shows is that we are probably falling victim to the bias, because most current clinical decision-making models provide a logical and reasoned approach for making judgments. But we know we know that there's really very little proof that we always think rationally. And there are many non-rational factors that influence our thoughts and our behaviors, which actually are never discussed.
Yes, because I know there's this idea, I think was it Daniel Kahneman talked about this idea of thinking fast and thinking slow.
Yes.
And that I suppose we have to have a fast system, an intuitive system to be able to function just in day-to-day activities. But yeah, I can see how there could be risks if we're using that sometimes, that kind of fast thinking, maybe in relation to our own clinical decision making. Is that something that you think could be an issue or a problem?
Yes, I mean, definitely. I mean, the work that Kahneman has done, and he did a lot of work with his co-worker, and then Kahneman, as you'll know, he won a Nobel Prize for his work.
Yes.
And basically, the essence is, as you describe it, that there are two pathways, if you like, two systems. There's system one and system two. System one is the brain's fast, automatic, intuitive approach. And system two is a slower, more analytical mode of thinking where reason dominates. Now, the brain isn't literally divided into two. These two systems work side by side and work in tandem, not as separate entities. Both systems, the science shows, both systems can be biased and we can make mistakes. So neither one is categorically good or bad. We just have to understand that actually there is scope for error when we're using those.
Yes, yeah. And, just thinking about, I suppose, dental healthcare practitioners in practice today, I think it's probably fair to say, Raj, that, patients are increasingly more demanding. Do you think that impacts the way, dentists and dental teams work?
I think it does, Noel, and it's an interesting question, actually. One of the things we should ask ourselves also is, why are they more demanding now? Is possibly the patients are better informed because they have more access to information, on the internet, for example. But I think part of the reason they're more demanding also is that as a profession, our marketing and advertising sort of strategies now are fairly, if I can use the word, aggressive.
Yes.
And sometimes without realizing it, we can set high expectations through the advertising and the marketing. And then we wonder why it is so difficult to meet those expectations. So I think that's the first thing to realize. In answer to your question, when patients are more demanding, what is it that we can do? I think we have to do two things. First of all, we have to lower the expectations when it's relevant, so the patient has a realistic expectation.
Yeah.
And secondly, we have to improve the effectiveness of our risk communications with patients.
Yes. And do you think it also fuels defensive practice, this kind of high expectation and, from patients being more demanding?
Yes, I think it does, no. I think generally speaking, as a profession, most clinicians now are, fearful of the consequences of getting it wrong, if I can use that phrase. And as a result of that, clinicians will practice defensively, perhaps focus sometimes too much on the risks. We talked in an earlier podcast about risk intelligence.
Yes.
If we haven't assessed the risk accurately, then we could actually be alarming them unnecessarily.
Yeah.
And that is a feature of defensive practice.
Yeah, that climate of fear, as you said, that we talked about in an earlier podcast.
Yes.
And just coming back to, I suppose, the whole area of clinical decision-making in dentistry, what do you think are the common biases when it comes to decision-making?
I think we have to recognize that most dentistry is delivered in a primary care setting.
Yeah.
A setting that has commercial pressures as well as clinical pressures. And I think the challenge is finding a path that allows a clinician to say with confidence, I am making the decision for this patient about the treatment based on the patient's best interests as opposed to the best interests of the business of dentistry. I think that is the greatest challenge.
Yeah.
And if I can go back to my example I gave earlier about the endodontic patient who has irreversible pulpitis, when you talk about the options for the patient, you can frame the options for the patient in two ways. So you can focus on the negative and say, look, there's a, let's say, 10% chance of this treatment failing, and try and nudge the patient towards an extraction and then have an implant afterwards.
Yes.
Or you can frame the risks in a positive way and say, look, 9 out of 10 times when we do this procedure, it will succeed. And then the patient is more likely to opt for the endodontic treatment. So we know from the psychological research that the framing of the risks influences the patient's decision. So a clinician who is motivated by factors other than the patient's best interests could unethically frame things in a certain way. And that's the challenge.
As mentioned. And just before we finish up, Raj, I know we've mentioned quite a bit about biases and cognitive biases and all that whole area. I'd like if you could maybe share with our listeners some, I suppose, practical strategies for whatever you call it, de-risking or de-biasing.
Yes.
That they can take away, and implement in their own practices.
So that's a really good question, though, and it's something which we must all do to avoid those biases from influencing our decisions, as you rightly say. The first thing, I think, with any strategy, the first thing to appreciate is to recognize that actually we can be biased. So we have to develop sort of insight and awareness. Yep. And also have an understanding of this dual process theory that we referred to earlier with Kahneman's work.
Yep.
I think the process of reflection is very powerful. After the event, to reflect on the treatment that you provided, the choices, and ask yourself the question, have I been objective? Have I been rational? Have I been unduly influenced by factors that perhaps are less than honourable?
Yeah.
We can force ourselves into certain decision-making models like checklists. I know from seeing on your bookshelf when we've done webinars in the past, one of the books on your bookcase is a book about checklists.
Yes. Atul Gawande.
It's Atul Gawande's book, and I have the same book, albeit an older edition. And checklists are very powerful. Which is why the airline industry uses them so extensively to this day.
And sorry to cut you, Raj, do you think, and just on that, just to tie it in, because you mentioned earlier about this Daniel Kahneman and fast and slow.
Yeah.
Do you think by using something like checklists, it actually forces us, maybe even subconsciously, to move to that slower, more deliberate, effortful thinking rather than just kind of quick-fire, intuitive? I'm thinking in relation to clinical decision making, that it's like a surgical pause, nearly, that it gives us time just to think and
it absolutely does. No, yes, you're spot on. It does force us down that particular pathway. What it also does is indirectly it provides an opportunity whereby we recognize that actually we need time to think.
Yeah,
we need time to think.
Yeah, and it reminds me of the old carpenter rule that measure twice, cut once.
Yes.
That just to slow down. Yes. I think that can be really useful.
And I'll just quickly add in also the value here of peer review and having conversations with colleagues, sharing cases and saying, look, this is what I decided to do here. Would you have done something differently? And if so, why? And not to be afraid of speaking to a colleague who may have a different view. I think, we should seek second opinions without, I think it's a phrase that actually I've heard you use many times. If I'm right, I think you've often said we should seek second opinions without, and I quote you, fear of ridicule, Noel.
Yes, yeah.
And I think that's very important.
Yeah. So, and on that note, I'd like to thank Raj once again for all those thoughts and insights, and also very practical debiasing and de-risking strategies for overcoming some of these biases that we talked about. So, to hopefully help us all make more unbiased clinical decisions. Thank you for listening to this podcast, Clinical Decision Making in Dentistry. I hope you enjoyed it, and if you have, please do tell your friends and colleagues. If you're a member of Dental Protection and want to know more about today's topic, please look in the podcast description for further information. If you're new to podcasts, perhaps listening for the first time, do please make sure to subscribe to the channel to make listening in the future easier. You can access this podcast from all the major apps, including Apple, Google Podcasts, Spotify, etc. For more information about dental protection, or if you are already a member and would like a certificate for listening today, please look for details in the description. I've been your host, Dr. Noel Kavanagh. Thanks again for listening.